Well, hello and welcome to Supervision. My name is Robert Ferow, LPC Supervisor here in the state of Texas. I am based out of Montgomery County, Conroe. In any case, you are watching Welcome to Supervision. This is a channel on YouTube that I created to help LPC-Associates, specifically the ones that I am supervising, as they grow and develop into full licensed counselors. This episode, we're looking at the DSM again. This one's going to be focusing on bipolar disorder type 1 and the specifics of it. I have to apologize, guys. This one's not going to be very lively and fun. I'll try to have some fun with it as much as we can. This is just really a review of the DSM. Now, if you are not one of my LPC associates, let's say you're getting supervision from someone else, you are by all means welcome to watch and hopefully gain some insights and understandings. Feel free to make comments and whatnot. I appreciate those. This channel is not monetized, and nor do I have any intentions of doing so. The purpose of it is purely to help associates learn and become better at what we do. So the expectations for this session are kind of straightforward, nothing really fancy or wild. We are going to be looking at the criteria for bipolar disorder type 1 specifically, and that's going to include the episodic nature of bipolar disorder, and there's 3 qualities to that we're going to look at specifically. Then there's also the features and prevalence, what makes bipolar bipolar, and the prevalence of it. How frequently does this hit in America specifically? The development and course of the disorder, how does it grow? And lastly, looking at prognostic risk factors, how we can determine if things are going to be getting better for them or getting worse, where they're at, and naturally what we can do to help. The DSM-5 text revision classifies bipolar disorder type 1 under the number F31. Now there's 3 categories that we have to take into account. Those are numbered differently, only after the decimal there. So we're going to have a mild category. In other words, it's not a severe level. These are all coding categories to let the insurances know how severe the case is. So we've got mild, moderate, and severe. 3 possible avenues. F31.11, F31.12, and F31.13. These all 3 are bipolar type 1, and they're just indicating to whoever will be looking at it how severe this case is, how messed up is the problems that the person is dealing with. Point 11, not too bad. Point 12, common, middle of the road problems. They have some life issues. Severe is where you're going to have categories where they've got legal involvement and they've got major employment and financial involvement. So all of these categories you want to take into account when doing an assessment. Specifically, pay attention to what the psychiatrists identify, and if you have questions, by all means, ask the psychiatrist that's over the case what made them choose moderate versus severe. What was the element to that case that helped them make their decision? Like I've said, and I will always say this, using a team approach in the hospital settings or in the outpatient settings is going to be one of your strongest resources of information. Going to the doctors, going to the nurses, get information from them. Their training and experience is different than ours, and it really helps to balance that equation. Now, the criteria for bipolar disorder falls under an episodic quality to it. It's going to have this nature where there's going to be manic episodes, hypomanic episodes, and depressed episodes. The diagnostic criteria for this is really made up of symptoms of mania that have to be present. They must be there. and they can be preceded by or followed by a hypomanic episode or a major depressive episode. Now, 9 times out of 10, the depressive episode is going to happen on the heels of the manic episode. The hypomanic usually precedes the manic. And we're going to look right now at just the manic episode. It's going to have 4 criteria categories, A, B, C, and D. Let's cover A real quick. I have B in front of you there. That one's going to be very important, but in order to get to that one, we have to cover A first, of course. This one reads as a distinct period of abnormally persisting, elevated, expansive, or irritable mood, lasting 1 week or more, present for the majority of each day. So out of those 7 days, more than 50% of it, the individual has this abnormally elevated mood or irritability. We're going to come back to that component here in just a little bit. But let's take a moment and look at category B, increased energy and activity with 3 or more of the following. So you have to have at least 3 of these in order for manic episode to be identified. The first one being the inflated self-esteem or grandiosity, a decreased need for sleep, and that one I have seen in almost every one of these cases. There's also more talkative than usual, or a pressure to keep talking. The speech itself can be pressured, but they can also come across like they just cannot stop themselves from talking. There can be a flight of ideas, the subjective experience of thoughts in their head racing like NASCAR. They just can't seem to slow down a thought to really focus on it and give it some attention. There's also distractibility, easily distracted and drawn to what to the rest of us would seem as really unimportant or irrelevant material. It has absolutely nothing to do with anything, but they're completely drawn to it. Next would be an increase in goal-directed activities, social, work, school, sexually aspects, psychomotor agitations. These also can present, the psychomotor agitation presents as being a purposeless, non-goal directed activity. So, for example, if the energy level is up, but they're not doing things, they're just kind of got that bouncing off the walls presentation, then that would be that purposeless, non-goal directed activity of psychomotor agitation. And lastly, we're looking at the excessive involvement in activities. Now, there's a caveat to this. They have a very high potential for negative, painful consequences. Some of the examples I've run into is all of these ones: multiple sex partners, high-risk sex activities, unprotected sexual activities, high-risk financial business investments. I had one years and years ago who the family had to intervene because this young man had gone through a large amount of money in his trust fund and purchased like an airplane, a yacht. We're talking like, millions of dollars of purchasing. And they were able to get some of it retracted and reversed, but there was a few things they couldn't, and the family was stuck with some equipment that they just did not want because the individual, during a manic episode, made purchases. And this is the negative consequence that comes from this manic episode quality of bipolar disorder. Oftentimes, my personal experience is that the individuals will kind of burn a lot of bridges financially, and they just end up burning all of that money out where there's none left, but yet they don't realize they've done it. In their mind, there's still more available to them. All right, so category C that's not on your screen there, but you can find it in a book on the DSM, is a move in disturbance sufficiently severe to cause impairment in social settings, occupational, and oftentimes hospitalization is required to prevent the ongoing nature of that negative consequence. Category D indicates a manic episode not due to substances or general medical condition. Now also there's an additional little notation in the DSM about the criteria A through D constituting a single manic episode, and that one is required in order to give the bipolar disorder diagnosis. If there is no manic episode, you do not have bipolar disorder. And now we're looking at the hypomanic episode. This one commonly, as I said earlier, precedes the manic episode, although it can follow. It's not as common. But here again, we've got some categories that we need to look at. I have posted B category in your screen there to see. But we do have 5 categories this time. It goes as far as F. So category A, distinctive period of time, persistent, elevated, expansive, irritable mood, present, persisting, increase in activity or energy lasting for up to 4 days. Now this is one of the differences between the manic and the hypomanic. This one has a 4-day requirement, whereas the manic has a 7-day requirement. Now category B, during this period of mood disturbance and increased energy, there are 3 or more of the following. So here again, we need to have 3 or more. The likelihood is you'll have more than that, so 3 is just the minimum for, that would be for the bipolar manic episode. The hypo requires 4 if the only mood symptom is irritability. Here's where I mentioned before. There's this little thing about that mood of irritability. If they're only irritable, they need to have 4 of these in order for it to be hypomanic. So the first one identified is the inflated self-esteem or grandiosity. This one is actually kind of interesting because it can come across as very flamboyant quality, very believable in many ways. The next one would be a decreased need for sleep, feeling rest after only about 3 hours of rest and sleep. Of course, again, we have more talkative than usual, or having the pressure to keep talking. There's also the flight of ideas, subjective experiences that their thoughts are racing. There's also the distractibility, drawn to unimportant, irrelevant stimulation. The increased goal-directed activity, work, social environments, school, sexuality, and it looks like I have a typo in there where it says psychomotor agitation. Not going to worry about that. It's not psychomotor, it is psychomotor. So there's a lot of energy coming out in leg pumping, fidgeting, the inability to sit still. Also, the excessive involvement in activities that have the high potential for negative consequences. It is still there. So at this point in time, you may be starting to realize some of these symptoms may imitate symptoms of other disorders. That's something to keep into account when you're looking at the differential diagnosis. Okay, so we're now looking at major depressive episode of the 3 episodic qualities that are present in this disorder of bipolar disorder type 1. We're looking now at category A as opposed to category B. This was the one that has the requirements of other qualities to it. So we need to have 5 or more of the following symptoms in a 2-week amount of time. Now notice we've got more time involved. So in the manic episode, we have 7 days. In the hypomanic, 4 days. Now in the depressive, it can be during a 2-week period of time. And it is identified representing a change of previous functioning of at least one symptom coming from depressed mood or the anhedonia, and then we have the rest coming out of that list of 9. So depressed mood most of the day, nearly every day, based on a subjective report. And it should be interesting to note here that the feelings of sadness, emptiness, or hopelessness is observable by other people. So you can actually see this. Their energy level is greatly diminished. Number 2 talks about that diminished interest or lack of pleasure in nearly every quality of life. And it's really obvious. Number 3, significant weight loss, not due to dieting or having weight gain. Can also include decreases or increases in appetite for nearly every day. It is important, though, to recognize they're not intentionally trying to lose weight. Number 4, insomnia, the hyper or hypersomnia. Here's where it's kind of an interesting side effect, I think, personally, is after the brain has gone through all of those brain chemicals that keeps the person in a manic episode, the following crash, they have to sleep. The body just it just gives out. Also, we're looking at number 5, the psychomotor agitation. Can also have retardation nearly every day. So there's either going to be a continuation of leg pumping and fidgeting, or we've got like a near catatonic kind of expression that we see happen, where they just have zero energy of any kind. Fatigue and loss of energy every day. Feelings of worthlessness or excessively inappropriate guilt nearly every day. A diminished ability to think or concentrate. Indecisiveness nearly every day. Are you kind of getting a feel of how it's nearly every day, all day kind of thing? Number 9 is one of the things we need to look out for. Recurrent cause of death. Not just a fear of dying, recurrent suicidal ideation without a plan, without specific suicide attempt, because this one has the potential for suicide. These individuals can really dive into the hopeless, helpless sensation of never getting out. Now, another aspect here, we've covered A, but B is really saying that the clinically significant distress or impairment occupies several aspects of an individual's life. Also, again, category C, things are not due to a general medical condition. This is where the MD is really going to shine with regards to them being able to rule out thyroid problems or other comorbid issues that we'll talk about in a little bit. It is also, I think, some additional notation. Symptoms of depression in this category are not due to grief and loss or bereavement, such as financial ruin, natural disasters, serious medical injury, or disability. Okay? Here again, like I was saying, this is where the MD really shines. I have worked personally with individuals that had head injuries, both open and closed, and they would experience bipolar type 1 symptoms, but because they had a head injury, bipolar type 1 was ruled out. So let's now look at some diagnostic features. I love this image that I found online. I have no idea who it belongs to, but I think it's absolutely amazing with regards to this kind of representing some of the visual image of what it would feel like. In any case, diagnostic features, the essential feature of this disorder is a manic episode consisting of persistently elevated and expansive or irritable mood combined with increased energy levels lasting well over 1 week, or at least 1 week minimum. The aspects of euphoria, excessive cheerfulness, feeling on top of the world. Now, I've actually had people describe this as if they could touch the face of God, that it was that amazing. I even had one gentleman years ago comment how he enjoyed the sensation so much it was better than using crack. Now, with children, we need to also point out we've got to be careful in this regard. Children are now capable under the age of 18 of receiving this diagnosis. And so the doctor is going to be looking closely at things like happiness, silliness, and goofiness that are normal in special occasions. But however, if these situations are not a normal setting for the child, and the people that know the child really well can say, no, this is way above and beyond their average age behaviors, then that might account for the diagnosis. Also, wanting to look at the mood changes that are accompanying that persistent increased activity level. Need to know the child really well to make that diagnosis. Overlapping activities is another aspect that should be looked at. If they're kind of doing what I like to call the 40-yard dash, jumping into things that they don't have the knowledge about, didn't bother researching and just dove into it, it's like, well, where did you get that ability to think that you can captain a sea vessel and all of a sudden one weekend say we're gonna take a ship up to San Francisco? Okay, that kind of thing. It's usually kind of dramatic. One of the most common aspects is the decreased need for sleep. This is followed by features such as the rapid pressure, loud patterns. They're difficult to interrupt. They can be all over the place, and they may talk right through someone else's attempt to interrupt and interject something. The flight of ideas, the expressive mood, optimism, grandiosity, poor judgment, hypersexuality, all of these things are diagnostic features that can be intermingled at the same time. Okay, and there's also associated features, things that are on the sidelines. For this, I grabbed some images just to give you an idea. Hats, glasses, a bow, a mask, a mustache. These are the things that are extra. So during a manic episode, individuals will often not be able to perceive that they are ill or in need of treatment or assistance in any form. Additionally, there may be observable changes in their clothing, their style of dress, makeup, personal experience. They can become more sexually aggressive, more sexually suggestive, or just more out there, more flamboyant. Also, kind of interesting, individuals that are in a manic episode or even the depressed episode may have a perceptual quality where their smell, their taste, their vision, their hearing all improves and becomes extremely sharp to smell and that kind of thing. It's quite interesting. Also, gambling and antisocial behaviors may also increase. Mood shifting from anger and depression can happen very quickly, especially in the last day or the last few hours of the manic episode. It's quite interesting how that mania can drop, and with the slightest comment, the person go from feeling on top of the world to being extremely depressed or extremely angry. So let's talk for a moment about the prevalence and development and course of bipolar type 1. In any 12-month period of time here in the United States, the prevalence is 0.6% of the population are going to have this disorder actively happening. And I did the math on this, and I had to double check it because it seems kind of high, but what that would constitute in the U.S. right now would be a little over, or actually a little under 2 million people. So it's 1,986,000 people would fall into that category of having bipolar disorder. Now the development, of course, average age of onset is somewhere around 18. I have seen it as young, personally I've seen it as young as 12, 13. With females, as they begin their cycles and they enter into menses and puberty. Not uncommon at that point in time. We want to be careful, though, in giving that disorder, that diagnosis disorder, to those under the age of 18. We want to be very cautious in going that route. Definitely get some work and collateral information from psychiatrists, have them do their evaluations. And here again, we want to identify that each child should be judged according to their own baseline. They're just real important. Now, additionally, it is also important to recognize that it is possible, although rare, for individuals as old as 60s and 70s to experience an onset of a manic episode, thereby getting them a bipolar disorder diagnosis. It's not often, but it can happen. And I bring that up because when I first entered into the mental health world, the idea was if they didn't have bipolar by the time they were at least 32, they probably would never get it. And most common was by 25. However, latest studies are now showing in the DSM-5 that 60s and 70-year-olds can get the diagnosis initial. So, important to recognize. Also, there's another developmental aspect with regards to individuals having had only a single manic episode in their lifetime that then are followed by having recurrent mood disorder episode without the mania, but moving into the hypomanic aspects. About 90% of individuals actually fall into that category where they would have one major manic episode and then the rest are only hypomanic, followed by the major depressive episode. Additionally, you will hear the topic of rapid cycling. Now, the definition of that in the development course, rapid cycling is defined as an individual with bipolar type 1 having multiple mood episodes of major depression, mania, or hypomania within a 1-year time period. And that's an important quality to pay attention to. Rapid cycling is not something that happens within a week or a month. I have had clients and patients tell me that they were rapid cycling and that they have had manic episodes and depressive episodes all within 1 month. No, sorry, does not happen. It has to happen over the course of 1 year of time. So let's talk for a moment about some risk factors: prognosis, culture, gender, suicide, and differential diagnosis. The image I got here, again, I borrowed straight from the internet, have no idea who did it, but it does, in my opinion, show some of the risk factors that we do run into with this disorder. I personally have had a couple clients in the course of my career so far that followed through with killing themselves in a depressive episode. So, some of the things we need to be aware of: bipolar type 1 is much more common in high-income individuals as opposed to low-income individuals. Additionally, some aspects of separation, divorce, or widow status, they're actually at a higher rate than those individuals that are actively married. Genetic and physiological aspects are found in families where there's a history of bipolar disorder, and that tends to lead to what DSM refers to as a 10-fold risk increase. So they got 10 times the chance of their children having bipolar disorder if they have a known bipolar disorder themselves. Also, additionally, this is kind of interesting. The DSM does talk about it, but not in a lot of depth. Schizophrenia and bipolar disorder share genetic origin, as well as that aspect. We need to be paying attention to the family history. So when you're getting your assessments, you're talking to them, find out from the family. Get a hold of the family, especially if this is a new initial manic episode. You're trying to rule out substance use and other things, because your client, if they're actively manic, they may not be a very good source of information. So you want to get a hold of the family and talk to them, asking them about family history, what is there, what's going on. If there's a family history of schizophrenia in the grandparents, it can sometimes show up as bipolar in the grandchildren. I've had that. I've seen it. It's quite interesting. Okay, also some cultural related aspects. There's very little information about culture in the DSM. They even say so. Gender related issues. Here, this is actually kind of fascinating. Females are more likely to experience rapid cycling as well as mixed state and have comorbidity patterns different than that of male counterparts. Additionally, females with type 1 or type 2 are more likely to experience depressive symptoms than males. Now, knowing that, the suicide risk of bipolar disorder is actually 15 times higher than in the general public. So that's why you really want to pay attention when these individuals are going into their depressive episode. Their chance of suicide attempt goes up times 15. And guys, that is a lot. All right, so some differential diagnosis that the doctors will take into account and you may also have to be aware of because the symptoms may mimic. They can be really hard to separate these out. Major depressive disorder, other bipolar type disorders, generalized anxiety disorder, a panic disorder, post-traumatic stress disorder, a substance-induced disorder, even attention deficit hyperactivity and personality disorders can mimic some of the symptoms of a bipolar disorder. So you really got to know your criteria well in order to help separate and parse these out. Comorbidity. This is a nice little terminology meaning shared death. These are situations where we have two occurring mental disorders that are very, very common that go together. Bipolar disorder tends to go along with some other issues that would include anxiety disorders, panic attack, social anxiety. Also included would be attention deficit disorder, impulsive mood or disruptive impulse control disorders, especially with the younger clients. Use of substances, guys, you really need to pay attention to their substance use history. In this category, it's almost guaranteed that they will have used something, either alcohol, pills, crack, cocaine powder, amphetamines, you name it, they're probably having tried it at least a little bit at some point in time. For example, the use of marijuana to help calm and settle down the mania, very common. The use of alcohol during a manic episode, very common because it is a depressant and they almost kind of instinctively know that. That's my own opinion on it. But a lot of times they will drink to excess simply because they, in a manic episode, they don't believe it's going to affect them. And they're so manic anyway that the alcohol loosens up everything else. And so they start making really bad decisions. So also, suicide rate is a higher risk if alcohol and substances are involved at the same time as a depressive episode. Here again, alcohol, bad combination for mania, even worse combination for a depressive episode. So let's talk about Hollywood for a moment. Hollywood is amazing with regards to sensationalizing or catastrophizing mental health illness, going as far back as movies like Reefer Madness, and there's so many to think of. In any case, bipolar disorder has not missed the bullseye from Hollywood, and here is a list of 8 movies that talk about or are specifically about bipolar disorder. I will say I have not seen all of these. A couple of them I had never heard of, in fact, but I did find this list on a simple online search. Several of these I realized I want to watch because I like some of the actors that are in them. In any case, yeah, there's a lot of them out there. So I would definitely encourage you to watch these, at least a few, to get an idea of what does bipolar disorder look like and act like, what kind of has its uh, quality to it. The one I'm planning on looking at is that Infinitely Polar Bear, 2014. Mark Ruffalo plays a father taking care of his kids at home because his bipolar disorder is so severe he's unable to work. And so that one, that's actually a very common theme. I've run across that many times in families where the husband or the wife has bipolar disorder and they're unable to function in society at a job. And so they're stuck at home looking after the family and the kids, which, as you can imagine, can lead to some traumatic experiences for those children, which in turn creates a vulnerability for them genetically and in their environmental experiences for trauma. And so when you're dealing with individuals that are married and they do have this disorder, you want to take into account some family therapy sessions, talk to the kids. It is highly encouraged that the kids may need their own counseling to help them develop the understanding. Now, let me bring up an important aspect that I talked about in another video of client education. This is one of those topics that we need to educate the families about and get them tied into some resources for their own knowledge and benefit for their own support systems. Because as you watch these movies, you will find these families are really struggling and hit with some difficult emotions as well as just unbelievable circumstances that they'll go through. And we're getting really close to being done here. And so let's talk for a moment about the screening tools, the different things you can use. I think one of the best places to look for this is the DBSA website, which is dbsalliance.org. Noticing we're looking at /education /mental health screening center. There's a couple out there, actually. One of the big ones you'll run into is the PHQ-9. That stands for the Patient Health Questionnaire. And there's 9 questions. It's a really good one, very direct. It's got lots of background research on it, proving its quality, being on top of the questions, what it needs to ask. It's doing what it's supposed to do. In fact, insurance companies do enjoy that one. So much so that a lot of hospitals and organizations are now requiring that screening tool to be used on every client. So if you're at a facility that is using one, you already know about it. If you're at one that doesn't use one, by all means, download it, print it, use it. It will really help you in the long run to get better acquainted with the kinds of questions you want to ask in order to rule in or rule out the criteria. Another one is the Hypomania Checklist. It's a self-report screening tool, also known as the HCL32. It's got 32 questions in it, and it's one that you can actually hand the client or the client's family members, and they can answer and check off themselves. Screening tools are important for us because it gives us one more thing that we can add to the documentation logs of their medical record. That way we can say, look, we're not just pulling this out of the blue and throwing it down. There's criteria that's being met. Now, having said that, let me talk to you for a moment about your documentation. As you are documenting a diagnosis, you want to be able to document the criteria that is being met for this diagnosis to be given. So if you have to open up your DSM, your pocket DSM, make sure you have your criteria laid out, then do that. And that way you can document that, yes, you're getting all of the 4 or 5 requirements, category A, category B, category C, and D. You can rule them in or rule them out. That way you're just kind of covering all of your bases. And there we have it. We have just covered the DSM's bipolar disorder type 1 review. And I've added a lot of my own information into it that I've run across personally. Some of it is my opinion, some of it is my observation, but I've also put in there the criteria from the DSM that you would need to know. Here again, guys, I really want to encourage you, get a DSM, open it up, read through it. You don't have to do this like, cover to cover, but you do want to, for a clinical level of counselor, you do need to know it well enough that you can spot these criteria very quickly, okay? Because if you are working in a hospital setting, you may find opportunity to move into a admissions office or in the categories of working in utilization review. You need to have that knowledge base to be able to move around within the healthcare setting and environment. Now, on the flip side of that coin, if you are planning on working primarily in the public schools as a counselor, then by all means you're going to want to know this material as well, because you need to identify it. A lot of these high school students are showing the symptoms and the signs of these disorders that you need to be aware of. Now, we have a third category. If you're planning on doing only or primarily a private practice setting, you're going to need to know these criteria as well, because you will also spot these individuals. It is amazing to me how often they will come in for counseling, and you'll be like, wait a second, we've got pressure of speech, we've got grandiosity, we've got a lack of sleep, we've got a weight loss or a gain. All of these criteria start showing up, and you may have to make a referral and say, is there any history in your family of schizophrenia or bipolar disorder? And if they say there is, it's like, I'm going to make a referral. I think it'd be a really good idea if you were to see a psychiatrist. That way you can get them the help they need. In many of these cases, that manic episode or the depressed episode can lead to some really bad outcomes. And if you're the first line of defense for these individuals, you really need to advocate for them and help them get the help that they need so that they don't destroy their lives or themselves in the process. Okay, so enough of that. Let's wrap up. I want to say welcome to Supervision. Thank you for listening. If you're one of my associates, I have probably asked you to watch this episode. We will talk in more detail about bipolar disorder at a later date, either in our group supervision sessions or in our individual sessions. Until then, guys, stay ethical, stay doing what you're doing. I know that as an associate, it is a difficult work level because you're getting overused at the hospitals, and it's like that nationwide. There's just a lot of work out there that we have to do, and it takes time to build up that awareness of how to get it done right. But you're getting there, so just remember, you are getting there, and you can do this. It's just, there's a lot of learning. You've been through a lot of school, but there's a lot more to learn as you go. But keep it up, doing a good job. Until next time, take care.